Scott Brown's Otology, Chapter 85, Ossiculoplasty, Introduction. This chapter covers the principles and practicalities of surgery to correct ossicular chain abnormalities with the aim of improving hearing. The surgical priorities when treating chronic middle ear disease are first to make the ear safe, then to make it dry, and finally to make it work. The last of the three is often the most difficult and of great concern to the patient, which is why ossiculoplasty can be both challenging and rewarding. Etiology. Conjunctive hearing loss due to ossicular chain abnormalities may be either congenital or acquired, and it is due to either ossicular chain discontinuity or fixity. Congenital. Deformities of the ear occur in approximately 1 in 15,000 births with isolated middle-ear disease abnormalities or minor malformations being less common than major malformations, which may also involve the tympanic membrane and external ear. Favorable results following surgical reconstruction of major malformations are dependent on the severity of the abnormality. The status of the ossicles, presence of the round window, pneumatization of the middle ear space, and course of the facial nerve are key determinants. Prognostic grading systems such as Jahdorfer score can be used to predict the likelihood of achieving good hearing outcomes. The diverse range of isolated middle ear deformities has been described, the most common being fixation of the stapes footplate, which may occur in isolation, which is often bilateral, or in association with stapes superstructure and other ossicular abnormalities. Epitympanic fixation of the ossicular heads and ossicular discontinuity are above described less frequently. The most challenging cases involve aplasia of the oval or round window. However, fortunately, these are rare. Surgery for congenital ossicular chain abnormalities should only be attempted by experienced otologists after careful consideration of alternatives, which include air or bone conduction hearing aids. Acquired. The majority of the ossicular chain defects arise as consequence of chronic otitis media with or without cholesteatoma. Ossicular chain erosion is much more common in the presence of cholesteatoma. The most common acquired abnormality is the erosion of the long process of the incus, which may be confined to the incudus-tapetal joint or extend a variable distance superiorly. The stapes superstructure may be partially or completely eroded, whereas the malleus handle is the most frequently preserved. Shortening or absence of the malleus handle is generally associated with subtotal perforations. Ossicular disruptions secondary to trauma may occur following direct injury to tympanic membrane. Barotrauma or temporal bone fracture. These defects are further described in Chapter 91, Ear Trauma. Idiopathic cases of resorption of the long process of incus in the absence of active suppurative ear disease have been described in the literature but are rare. Classification of defects. The value of a classification system is to enable systematic description of preoperative ossicular status to facilitate meaningful analysis of surgical outcomes. Given the multitude of surgical approaches for correcting ossicular chain abnormalities, it is essential when evaluating results that the pathologies are comparable. While each patient will present a subtle, unique anatomical situation, defects can be broadly characterized by the presence or absence of different components of the ossicular chain. The most widely used classification system is Austin-Carshot system, which applies to situations without an intact incus. First proposed by Austin in 1971, 4 distinct anatomical situations are described in Table 85.2. This was modified by Cartouche in 1994, with the addition of 3 further categories to include a normal ossicular chain and cases of fixation. Situations not covered by Austin-Cartouche classification are rare and include isolated malleus handle fracture and fracture of the stapes superstructure. The classification also makes no specific allowance for partial incus erosion where incus remnant preservation is attempted. Prognostic factors. The ideal scenario in which to perform ossiculoplasty is in a stable, well-ventilated middle ear with an intact tympanic membrane in the absence of ongoing middle ear infection or cholesteatoma. Absence of any of the above factors increases the risk of failure, as do patients' factors such as smoking status. The Middle Ear Risk Index (MERI) was devised by Kartosh in 1994 and generates a numeric value which corresponds to severity of disease and the likelihood of a successful outcome following surgery. This can be used to guide case selection and counseling of patients preoperatively, but is perhaps most useful for research purposes. It is an amalgamation of the Austin-Kartosh classification of ossicular defects, the Belosi classification of Otology, and takes into consideration the presence of tympanic membrane perforation, middle ear granulation, and cholesteatoma.